From April this year, both Kate and myself have been going around to meet with all the heads of midwifery and directors of nursing in all the trusts across the whole of Midlands and East. One of the key topics that we've been discussing is how they plan to implement AEQUIP and their plans for the model. And in fact, actually, we've been quite surprised at how well received the model has been across the piece. So the majority of our homes have got a plan in place, and some of the DONs are looking at how they might roll the model out for nursing in the future.
We started off on the 30th of November. We launched ourselves as a group of PMAs, and we went around the entire unit and across the hospital just to say who we are, what we're going to be doing, and at the same time we went around handing out leaflets to everybody so that they had a visual reminder as well about what PMA is and what we're hoping to achieve. Because we're still a relatively small team, we plan to take it forward by offering drop-in centres, drop-in clinics for midwives and the maternity nurses to attend whenever they're available. We want to send this out to all the midwives via a global email so that they know that it's happening and where we're going to be and when they can find us and how they can access us.
We chose to look at the 4 concepts of the AEQUIP model. So a group of the PMA's team, they sort of went away and looked at each area to say how they could implement each aspect of it. And then we brought it back and decided the framework would include the 4 areas, but also the key lines of inquiry from CQC. So we wanted to assure our women, our staff and our trust that we could, through the PMA model, that we could evidence that we were still caring, safe, that we could be well led, and those elements that we included to build around our framework. And I think the key for us is being available and approachable, and we are all very well embedded in clinical practice as well. I mean, we're quite often in a set of scrubs or a uniform working, and that's held in high regard by the midwives, that we can understand their role, that we can understand the challenges that they face, and we can help them with it.
Now our community midwives know that there is PMA's access that they can get between the hours of 8 and 4, so office sort of hours. So if they've got anything that's outside of our remit, our guidelines, they know that they can contact any of the PMAs or the one that's on call for that day, so that they can ask for advice, support, or any guidance that they need. And they know that if there's anything they just want to put past us, a guideline, or that they've discussed with the Women in Care plan, that we were available.
So our plans to further embed the AEQUIP model across our local maternity system include the appointment of a countywide PMA, her sole purpose is to lead the PMAs and take this forward. Within the next month, all of our qualified midwives will have a named PMA from across the local maternity system, which is a huge step forward based on the number of midwives that we have across the LMS.
We're going to be really responsive to any situations where midwives need support or women need us to be advocates for them, which we're really excited about.
I think that the PMAs will benefit from the model entirely, in particular restorative supervision, which we feel from commencing the programme is going to be more of the change, a bigger challenge, but it's an exciting challenge, and it's a way that we can invest in our midwives and our future student midwives as well.
The evidence base in relation to restorative clinical supervision is strong, and it's good when we're moving forward with a new model to have a strong evidence base for the professional midwifery advocate. There has been a gap between the end of statutory supervision and the start of the AEQUIP model and the roles of the PMA, and within our groups that we've been talking to on the bridging programme, they've identified that midwives do need that support, both in the hospitals, in the community, in the trust, and here as student midwives as well.
I think restorative clinical supervision will make a huge difference. I've been fortunate enough to receive restorative clinical supervision and was quite overwhelmed really about the impact it had on me as an individual and as a midwife. It's one of those things that you need to receive it to be able to understand the benefit, and I think midwifery is a really challenging career. Working in the NHS is really challenging. We need to build the resilience of our midwives and to be able to restore them from areas of high stress, and this will do that perfectly.
We felt that keeping the restorative clinical supervision sessions separate from their appraisal was quite important, because we didn't want the midwives to feel that this was a management thing. We wanted them to feel that they could come and talk to us about anything that was on their mind, anything that was bothering them, and so we wanted to keep it completely separate. As part of the preparation for their session, we would like to get in touch with the midwife beforehand, or the nurse, and ask them to think about something that they've been involved in that they'd like to reflect on, and then we can take that reflection that we talk about during the session and they can use that as part of their revalidation process.
So in relation to reflection, we've got fantastic acts with our lecturer. One of our PMAs is actually from the local university. The midwives can access her directly, or that as the PMAs can approach her and ask her, and it might not be done immediately, but it can be done within a timely manner so that they can approach, so they've got support with writing reflections and just having them read.
With midwives that need to write reflections, I'm very happy to help to support them in that, to help them. A lot of midwives haven't actually done a literature search for a long time, so help them with their literature searching, with the formulation of their reflection and reading their reflections and telling them actually, are they meeting the outcomes? Do they need to go away and look at something in a bit more detail, and how they're getting on really.
As far as quality improvement goes, we are going to be asking for the midwives before they come for their session to have a think about anything that they would like to do to help to improve the patient's experience here, the women's journey through with us, and then we can work on that when we do the supervision session with them. As part of our own PMA role, we intend to be involved in the patient safety and quality meetings. We're going to be part of the maternity voices meetings that are coming up, and we'll be taking things forward from there. We can also highlight lessons learned from incidents that midwives have been involved in, that staff have been involved in, and pass that learning on down to the midwives as well for them to disseminate out to their colleagues. And as part of the group restorative clinical supervision sessions, then we can also talk about incidents and how well we've managed them, or if there was anything that we needed to improve on and how we could take those things forward.
I think when we were supervisors of midwives, we were often seen as having all the answers and solutions to any issues midwives come to us with. But actually, that title didn't give us a unique mindset on improving care for women. It's really, I think the AEQUIP model facilitates us being able to support midwives in identifying how they can identify their own personal actions. So that means that it's intrinsic for everybody. Everybody will improve the care of women. In a small way or on a large scale quality improvement project. It can sometimes be just really small actions that supporting the midwives to identify and giving them skills and how they can implement small changes, or even larger scale quality improvement projects.
The main area that we know is a big change is the maternity transformational programme, and looking at the Better Births document and how we're implementing that in line with the framework. So we're still looking at maybe another year so we can refine some of the areas and still develop as to know what the midwives wish to have, and then put something in place there.
We want to be supporting midwives to help those women who choose care outside of the norm, and we want to be supporting the midwives to support those women without actually disempowering the midwives to do that for themselves.